Hello, my name is Christina Miyawaki. I'm an associate professor at the University of Houston, Graduate College of Social Work. I'll be presenting one of the projects I conducted during my Texas RCMAR Scholar Year between 2020 and 2021. It is called Social Support as a Moderator of Physical Disability and Mental Health in Older Vietnamese Immigrants in the US. Result from the Vietnamese Aging and Care Survey. I worked on this study under the mentorship of Dr. Kyriakos Markides at the University of Texas Medical Branch at Galveston. After the fall of Saigon in 1975, many Vietnamese immigrants and refugees arrived in the US. This year, it is said there are 2.2 million Vietnamese living in the US. Vietnamese Americans are the sixth largest foreign-born population and fourth largest Asian origin subgroup. However, due to the wartime experiences of violence and traumatic escape, Vietnamese Americans are a vulnerable population. Despite this fact, health studies on this population are limited. The limited studies shows that the health of Vietnamese was poor compared to other racial and ethnic groups. They have the highest ADL disability rates among Asian Americans. Vietnamese older adults show the high prevalence of depressive symptoms. Loneliness is another common mental health issue among older adults. Loneliness is associated with detrimental physical, mental, and cognitive health. Studies on loneliness in Asian communities have been limited to older Chinese and Korean immigrants only. And we don't know how Vietnamese older immigrants are handling this issue. Social support is a reciprocal, accessible, reliable social relationship that provides resources and helps with stressors. Older immigrants tend to count on social support from family, neighbors, and religious organizations. Especially vulnerable older Vietnamese immigrants need social support. However, the question is, how does social support facilitate older Vietnamese immigrants' well-being? Houston holds the third largest Vietnamese population in the US, and most recent data state that over 130,000 Vietnamese people live in the greater Houston area. To fill the knowledge gap of mental health issues in Vietnamese older adults, we developed the Vietnamese Aging and Care Survey and collected data in 2018. So the purpose of this present study was to report on the health status of older Vietnamese immigrants, examine the association between having a physical disability and their mental health, and test the possible moderating role of social support in the older Vietnamese immigrants' ADL disabilities and mental health relationships. We used a number of ADL disabilities as physical disability and depressive symptoms and loneliness as their mental health variables. There are two hypotheses in this study. Hypothesis one is that older Vietnamese immigrants who have more ADL disability would experience higher depressive symptoms and loneliness. And hypothesis two is that social support moderates the effect of ADL disability on depressive symptoms and loneliness. This is the conceptual model of the study. The inclusion criteria of older adults are that they are 65 years and older, they self-identify as Vietnamese, and they speak English or Vietnamese, and they live in Houston at the time of the survey. They are limited to community dwellers only. For data collection, we established rapport with Vietnamese social service agencies from 3 to 4 years prior to the survey. We hired several Vietnamese bilingual bicultural research assistants We use study flyers in English and Vietnamese and use snowball sampling and word of mouth. We recruited participants through Vietnamese community gatekeepers from Vietnamese social service agencies, Vietnamese senior housing, and Vietnamese faith organizations. We provided a monetary incentive as a store gift card of $20. The survey interview took about 20 to 25 minutes per person, and the final sample size was 132 surveys. We measured depression using the 20-item CST and set a score of 16 and above as clinical depression. For loneliness, we used the UCLA loneliness scale and 6 to 9 as lonely. Sociodemographic variables included age, gender, education years, living arrangement, number of ADL disabilities, chronic health condition, that's covariance. We translated and back translated between English and Vietnamese all instruments except CSD, because the CSD has existing Vietnamese version. We use t-test and chi-square test to compare continuous and categorical variables between older adults with high depressive symptoms or loneliness and those who do not. We use linear regression models. We started with model 1, which is a crude model, the association between number of ADL disabilities and depression and loneliness. Number 2 is another crude model, but examine the association between social support and depression and loneliness. Number 3, model 3, examine the interaction term between disability and social support to test the moderator role of social support. Model 4 is an interaction term adjusting for covariance. These are the results. Table 1 is the result of characteristics of older Vietnamese immigrants. Due to time constraints, I will report only the statistically significant results. The total sample size of this study was 132. Their mean age was 75 years old, and their age range between 65 and 90 years old. All of them are born in Vietnam, but have been living in the US for 27 years. The vast majority of them live with other people, including spouses, adult children, and grandchildren. 77% of them self-rated their health as fair or poor, but their score on social support was relatively high. Table 2 shows the characteristic of those who have depressive symptoms and those who don't. Those who have depressive symptoms tended to have poorer health with more ADL disabilities, as well as dementia. Table 3 shows the characteristics of those who feel lonely and those who don't feel lonely. Those who are married have a fewer number of ADL disabilities and have stronger social support tended not to feel lonely. Table 4 shows the result of linear regression model predicting depressive symptoms. To examine hypothesis 1, ADL disabilities showed positive association in model 1 and model 3 and remained positive in model 4. But other than that, receipt of social support and any sociodemographic characteristics had no statistically significant association with depressive symptoms across 4 models. To answer hypothesis 2, the interaction term between ADL disabilities and receipt of social support was also insignificant in model 3 and model 4. Table 5 represents the association between ADL disabilities, receipt of social support, and feelings of loneliness. ADL disabilities show strong positive association with loneliness in model 1, model 2, and model 4, which is the answer to hypothesis 1. Receipt of social support significantly moderated the relationship between the number of ADL disabilities and feelings of loneliness in model 3, with its moderating effect remaining strong after adjusting for physical health and social demographics in Model 4, which is the answer to hypothesis 2. So the number of ADL disability was significantly associated with high levels of depressive symptoms, which is consistent with the previous work across different racial and ethnic groups of older adults. However, receipt of social support did not have a strong association with depressive symptoms, which was a surprise because previous studies with older Korean and Japanese immigrants shows that lack of social support was strongly associated with high depressive symptoms, and emotional support moderated the influence of life stress on depressive symptoms. Because these older Vietnamese immigrants tended to live with families, their instrumental and emotional support are readily available. Such living arrangement may alleviate their physical disabilities and prevent them from being depressed. We also found a strong association between the number of ADL disabilities and loneliness. The more disabilities they had, the higher level of loneliness. This relationship has been investigated in various racial and ethnic groups across different countries. However, the results have been inconsistent. The associations between receipt of social support and the absence of feelings of loneliness in this study were in the expected direction, but it was not statistically significant. However, the interaction term identified receipt of social support as a moderator of the relationship between ADL disabilities and feelings of loneliness, meaning that among those who received more social support, ADL disabilities were associated with lower loneliness compared to those who received less social support. As previously mentioned, older Vietnamese immigrants tended to live with relatives within ethnic enclaves. They are surrounded by their families living next to each other, interacting and communicating in their native language daily, and therefore they are hardly alone. So this living condition provided strong social support and positively influenced their feelings among older Vietnamese immigrants. Living in Vietnamese enclaves and having access to their families, relatives, and peers looks like a good solution to satisfy older Vietnamese immigrants' emotional needs. Here are some limitations of the study. This is a cross-sectional study with a small convenience sample, and therefore the results are not generalizable, and no causal relationship can be predicted. Some older adults are recruited from Vietnamese adult daycare centers, and so they tended to be active, independent older adults. The relationship between ADL disability and depressive symptoms, as well as loneliness and depressive symptoms, can be bidirectional. Despite their midlife migration and refugee experience, Vietnamese older adults in Houston area are supported by tight family units. Healthcare professionals can facilitate access to more existing social and health services, such as senior centers and adult daycare centers that provide culturally and linguistically appropriate congregate meals and group physical activities. For those older Vietnamese people with a higher number of physical disabilities, Vietnamese home care workers can be helpful to cook ethnic meals and communicate in their native language. This way, homebound older adults can be cared for while their family members work outside the home. I would like to acknowledge my Texas RCMAR funding here. And this manuscript has recently been published in geriatric nursing. My co-authors are Dr. Mingwei Liu from the Central South University in China, Dr. Van der Park from the University of California, San Francisco, Ms. Mindy Tran from the University of Houston, and Dr. Kyriakos Markides from the University of Texas Medical Branch at Galveston. Thank you very much for listening to the presentation. All of the references are listed in slide 26. 27, and 28. Thank you very much.